The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Welcome, and thank you for joining us tonight for the TAS 120 clinical trial and cholangiocarcinoma updates. I am Melinda Bikini with the Cholangiocarcinoma Foundation, and I will be introducing our presenters for this evening. We have Jerry Hong from Taiho Oncology and Dr. Lipika Goyal from Boston Mass General. And I will pass it over to Jerry.
Thank you, Melinda. Good evening, everybody. In the next 40-50 minutes, we are going to share with you first about TAS 120 in cholangio, followed by the Q&A session. So before we start, I just want to show you the disclaimers. What we are going to present, both Lipika and myself, is the information for the information purpose only and should not be considered as advice. And any of the treatment specific questions should be referred to your treating physician. And we will only present the data that has been previously presented at the scientific conference. Just for your information, Dr. Lipika Goyal is our lead investigator for the TAS 120 study, and I am an employee of Taiho Oncology, and I'm a VP in clinical development. So I am going to pass the presentation to Dr. Goyal to present the data on TAS 120, which was presented at this year's World Congress on GI Cancer in June. Dr. Goyal?
Thank you. Yes, thank you, Jerry. Thank you, Melinda, and welcome to everyone. My understanding is that they're both patients and providers on this webinar, so I'll try to speak to both, and we're excited for you to be able to join us tonight. Go ahead, Jerry. So I'm going to start by talking a little bit about cholangiocarcinoma, and then I will move on to the data that we have to date on the TAS 120 drug. So as many of you know, cholangiocarcinoma is a cancer of the bile ducts of the liver, and there are about 5,000 to 10,000 cases of it per year in the United States and thousands more globally. And one of the big advances in cancer has been trying to identify what are the drivers of people's cancer. So what are the mutations, the abnormalities in the DNA that are causing the tumors to grow and spread, and then seeing if we can come up with medicines that can shut off those pathways. And what we found in 2013 by the group at the University of Michigan was that about 15% of patients have an alteration called an Fgfr2 fusion. And through a series of sequencing efforts, we've also found another 5% of patients have other mutations or amplifications in the FGFR pathway. And this is specifically mainly seen in patients with intrahepatic cholangiocarcinoma, but occasionally we also see alterations in FGFR in extrahepatic cholangiocarcinoma. We also know that cholangiocarcinoma is a very tough disease, and right now in terms of FDA-approved treatments, we have gemcitabine and cisplatin, which is standard chemotherapy that we give in the first line. But what we're looking for is other drugs that we can get approved in this disease to help people live longer and live better. And so the identification of the FGFR2 fusions has been very exciting because it gives us a chance to give people something in the second line and in the third line. And what do we know about how well chemotherapy does after the standard gemcitabine and cisplatin? We know that on average, people get about 3 months out of chemotherapy, and that generally about 5 to 10% of people have significant shrinkage of the tumor. So we certainly need to do better with that, and we're seeing some encouraging data with the FGFR inhibitors like TAS 120. On the right, we see basically a very complicated diagram showing that the FGFR pathway is a complicated signaling pathway in cholangiocarcinoma, but that also there are different ways that FGFR can be altered. Sometimes it can be a fusion, sometimes it can be a mutation, sometimes it can be amplification. The fusions look like they're the ones that are the most sensitive to the different drugs that we have, but we're still finding an encouraging signal in some other patients as well. So what have we found so far with TAS 120? So a little bit about the drug. It is a pill that is given once a day. And based on the dose we have right now, it's basically 5 pills that we give once a day. And it is an irreversible inhibitor, which means that the way I describe it to patients is that it's like a pit bull. It just grabs onto the FGFR receptor and doesn't let go. And that makes it a very special kind of drug compared to some of the other drugs that are out there because of the fact that it's like a pit bull and doesn't let go. So far, this drug has been given to 130 patients as of February 2018, people who have different kinds of solid tumors, which means tumors in an organ. And of those, 45 patients have had cholangiocarcinoma that have gotten what we call an efficacious dose, so either 16, 20, or 24 milligrams. Among those 45 patients, 28 of those patients have had the FGFR2 fusion that you see on the right, and 17 of the patients have had other types of mutations or amplifications in the FGFR pathway. Notably, on the right side with the FGFR2 fusions, 8 of the patients had a different FGFR inhibitor before going on to TAS 120, and 1 patient actually had extrahepatic cholangiocarcinoma as opposed to intrahepatic cholangiocarcinoma. Mainly, the presentation is going to focus on the patients that have had FGFR2 fusions, but we will also share some data for the patients that had other kinds of alterations. So among these 45 patients, as you can see, the majority of the patients have been female, 75%. One of the things we do see with these FGFR2 fusions is we do tend to see them in young females. The median age on the trial is 54 years old, but as you can see, we've had patients as young as 29, but also as old as 73. The majority of patients on this trial have been Caucasian. 91% have had intrahepatic cholangio. And then the last set of data is on how many previous lines of chemotherapy they've had. And as you can see, 29% of people have had 1 previous regimen, 29% of people have had 2 previous regimens, but at least 40% of people have had multiple lines of therapy before going on to this treatment. That shows a couple of things. One, we tend to see that patients who have FGFR alterations, they tend to live longer. They tend to have slower growing disease, and they have the opportunity to go through 2 or 3 or 4 lines of therapy, when sometimes some other patients with cholangiocarcinoma may only get 1 line of therapy. So we find it encouraging when someone has an FGFR alteration. And then also interestingly, with this study, 29% of patients had a prior FGFR inhibitor. And to my knowledge, I don't know that there are any other trials on the market right now that are allowing patients with other FGFR inhibitors. And we'll show you some data about how people do on this drug after they have had another FGFR inhibitor. An important question whenever we're prescribing a medication for patients that we look at as oncologists, and patients of course also ask is, doc, what are the side effects? So this is a slide about what are the side effects from this drug. So the most common side effect from TAS 120 and also other FGFR inhibitors is something called hyperphosphatemia. Phosphate it's like a salt in your body. It's kind of like calcium. And this drug, because while we wanted to hit FGFR2, it also hits one of the other FGFRs called FGFR1. And because of that, it's hard for the body to get rid of phosphorus, both through the urine and through the stool, and the phosphorus goes up. Now, we have lots of ways that we can address this by giving people pills to bring down the phosphorus, and also by giving people a handout on what a low phosphorus diet is. And we found that only about 20 to 25% of people had more serious hyperphosphatemia, but again, we were able to treat this in a majority of patients. The other side effects we see are constipation. The AST and ALT are liver tests, so we see liver test elevation in about 1/3 of patients. We see diarrhea in about a third of patients, but as you can see, only 2% have serious diarrhea, which means more than 10 bowel movements a day. About 30% of people have dry skin, and about a quarter of patients have dry mouth, and about a quarter of patients also have nausea. The palmar-plantar erythrodysesthesia syndrome is a fancy term for having a set of rashes that you can have on your hands and feet, and we see that in about a fifth of patients. And the stomatitis is a fancy term for having mouth ulcers, and that's also seen in about a quarter of patients. Now, the next question we always look at as oncologists and what patients always ask is, how well does it work, doc? So we're first going to look at how well this drug works in patients who have FGFR2 gene fusions, and then we're going to look at how well it works in patients who have other FGFR alterations. So we looked at 28 patients who had fusions, and 24 of these patients either had at least one scan, so we could see how well the drug was working, or they came off the trial for a variety of reasons. So among those 24 patients, we saw that 20 of the patients, so the vast majority of them, had some degree of tumor shrinkage. And the gold standard of one of the things we look at in oncology is what percent of patients had at least 30% shrinkage of their tumor and 30% shrinkage that lasted for at least a month. So it wasn't just something transient, but actually lasted. And that's what's called the ORR, the objective response rate. And we found that 25% of people had significant shrinkage. And those are the bars that you see on the right, the blue bars that go below the dotted line. Each of those bars represent one patient, and any of the bars that are going downwards show tumor shrinkage. The numbers on the left show the percent of tumor shrinkage. So you can see the patient all the way on the right had about 70% tumor shrinkage on this drug. And 7 patients overall had at least 30% shrinkage that lasted for 1 month or longer. The other thing we noticed was that 15% of patients had their disease stay stable, so not growing or spreading significantly. And overall, we found that 78% of patients had some degree of benefit from this drug. And again, just to contrast that to what we showed on the first slide, usually people get about, only about 5 to 10% of people get tumor shrinkage with second-line chemotherapy. So this kind of response rate is encouraging for this disease. The other thing to point out on this is any patient that has a star above their bar means they had a prior FGFR inhibitor. And as you can see, there are at least 3 patients who are in blue who had a prior FGFR inhibitor, and then they still had significant shrinkage when they got TAS 120. And then you can see an additional 4 patients that had either a little bit of shrinkage or their tumor stayed relatively stable when they were on TAS 120 after getting a prior FGFR inhibitor. So that's something encouraging in terms of thinking about sequencing. The next question people ask is, okay, the tumor is shrinking, but how long do I get the benefit from the drug for? And so this is a plot looking at how long people were able to stay on the drug. So on the bottom axis, the x-axis, that is the time in the number of months. And on the left axis, the y-axis, that is the probability of the patients being alive. And as you can see, that the median duration of treatment was about 7.5 months. And there's a plus sign there because there's still a lot of patients, 15 of the 28 patients, who are still on the drug. And so we haven't actually reached what the median is. So the progression-free survival, or the amount of time people are on drug, usually with second-line chemotherapy, is around 3 months. So we feel encouraged by the fact that for this drug, people are on it for 7.5 months plus. And again, just to review what median means, it means that there are some patients, and I've had patients who have been on the drug for more than 15 months, and there are other patients that are on the drug for only 3 or 4 months. So median is, 50% of patients, where do they fall? And they fall at about 7.4 months. So the next thing we're looking at is people who have FGFR mutations or amplifications, but don't actually have the fusion. And the good news is patients with other kinds of alterations also get benefit. So the 3 people on the right, those are people with FGFR2 rearrangements, which is another kind of gene abnormality. And as you can see, they all had more than 30% shrinkage. And then there are other patients in red who also had some degree of stable disease or the tumor not growing or spreading. There was one patient that unfortunately did not get benefit from the drug and immediately had growth of their disease. But as you can see, the vast majority of people, even with other FGFR alterations, did get benefit from the drug for a period of time. So overall, the data shows that TAS120 demonstrates benefit in patients with cholangiocarcinoma that have FGFR2 gene fusions. And it also shows benefit in people who have had a prior FGFR inhibitor. The most frequent side effects were expected, and they were all manageable with different drugs. Those included high phosphorus, some rashes, and some nausea and diarrhea. And overall, I found that my patients generally tolerate the drug very well. And we have patients that come from Ohio and even China and Pennsylvania, New Jersey, and they all come to Boston back and forth to be able to be on this drug. And we find that people are able to have the energy to travel back and forth. Right now, the phase 1 dose escalation study that was presented back in April at AACR in 2018. And the phase 1 dose expansion right now is currently recruiting multiple different cohorts. So while we're recruiting patients who have cholangiocarcinoma, who have different kinds of FGF and FGFR aberrations, we also find that patients with glioma, which is a type of brain cancer, also have different kinds of FGFR alterations, and they are patients who can join this trial. And then we also have a basket of patients with any kind of cancer that's from an organ, so like breast cancer, lung cancer, who have different kinds of FGFR alterations. They can also join on the trial. The trial that we're also very excited about is the phase 2 trial. The phase 2 trial is looking to enroll patients with cholangiocarcinoma that have FGFR2 gene fusions. And we're always happy to talk about this further if you have any questions about it. And I think, Jerry, this is where you're taking over. Is that right?
Yes. Thank you, Lithika. So what I'm going to show you in the next few slides is to share with you where we are in terms of the current clinical trials in cholangio. So there were 2 parts of study right now. One is the phase 2 part of the study that Dr. Goyle have mentioned. This would be focusing on patients with intrahepatic, and the patient need to be screened by Foundation Medicine with the molecular testing. Patients should not have prior FGFR inhibitor in the phase 2 part of the study because we would need to have a more or less homogeneous population in order to assess the efficacy. The patient need to have prior gemcitabine and cisplatin. At least one of the chemotherapy need to contain that, and the patient need to have the tumors with certain size. We call them measurable lesions, which is at least 1 centimeter in diameter, and the patient need to have a progression on their CT scans prior to enroll to TAS120. The other part of the study in the trial is the phase 1 expansion, which is to enroll patients who have not had any prior chemotherapy. We call chemo naive. So this is the map that my colleague Jim has produced for us. So what is, you see the green dot, these are the clinical sites. currently is active in recruiting patients to the TAS 120 study. What's in the red color, these are the sites that's currently in starting up to be activated to enroll patients. So I think that's what I have, what we have for the presentation. Melinda has forwarded us some of the questions in advance, so we can look at these questions first and respond to these questions and then open up for the Q&A. So I'm going to read the question, and some of the questions will be addressed by Dr. Boyle, and some of the questions I will respond to. So the first question is, why does TAS 120 stop working for some after about the 6 months period? Dr. Boyle.
So that's a very good question. We are actively starting to study this over the past 2 years. We know that in lung cancer also, when people have mutations like FGFR, in lung cancer people have EGFR, ALK, these are other mutations, people also get somewhere between 6 months and 2 years out of those drugs. And we've learned a lot from lung cancer about how people develop mutations in the receptor right where the drug is trying to bind, or sometimes people develop other mutations in the cells that make the cells stop responding to the drug. So we're actively studying why people stop responding so that we can figure out better strategies to help people respond longer. That might be adding a second drug to TAS 120. That might be giving a second drug after TAS 120. We're trying to figure that out to help people get more benefit for a longer period of time. One of the things that helps with figuring that out, which we often do for our patients, is we'll often do a biopsy at the time where it stops responding, and then we look for any new mutations to see what drug your oncologist can choose next. The other thing we sometimes do is check the blood serially over time, because tumors shed tumor DNA into the blood, and that's a way to non-invasively, meaning without a biopsy, measure what's going on with the tumor and monitor the tumor closely, and also see what kind of mutations might be popping up to help us figure out what's the next best drug for you.
Thank
It
you.
looks like the next question is, is this treatment appropriate for patients who have progressed in the biliary ducts and who need stents or a catheter for bile drainage? That's a very good question, because a lot of our patients certainly do end up needing stents in their bile ducts or do need a catheter for drainage. So I would say that it depends. It really all depends on what the liver tests look like after that stent or catheter is placed, because the liver is very important in order to be able to process drugs. So if the stents or the catheter are successful in being able to drain the bile ducts very well, and the liver tests come down sufficiently where you meet eligibility for the trial, then there's no specific reason why having a stent or a catheter would prevent you from being on the trial. But of course, you would just need to meet all the eligibility criteria for the trial. The next question is, what are the main side effects seen in most patients in the trial? So we briefly mentioned that in the presentation. I would say the most common side effects are having the high phosphorus level, which we can manage by having people take a low phosphorus diet, having people drink enough water and move their bowels enough so they can get rid of their phosphorus. And then also we're able to give pills that people can take with meals to help bind their phosphorus so that can be removed from the body. We also see some nausea, some diarrhea, and people sometimes get dry eyes and dry mouth. And every once in a while, people can get a little bit of a rash on their hands or a little bit of change in their nails. I would say those are the most common side effects.
Okay, I'm going to read the next question. Can a patient with cholangiocarcinoma who wasn't able to get genetic testing still be a candidate for the trial? Unfortunately not, because TAS 120 is only targeting those patients with the genetic abnormality, namely the FGFR aberrations. However, if the patient has not had the genetic testing, Taiho will sponsor or will reimburse the cost for the testing, or the patient can have the local testing for their FGFR aberration status.
Yeah, and just to echo what Dr. Huang is saying, this is really important because we want to make sure that this drug is going to work for you. So we want to make sure that you actually do have an FGFR2 fusion or some other aberration in FGFR so that this drug makes sense for you. Otherwise, your oncologist might want to choose a different drug that would make more sense for you. The next question is, why is ascites common after getting off this drug and other FGFR2 targeted drugs? That's also a good question. One of the places that cholangiocarcinoma can spread to is what's called the peritoneum, or the lining of the belly. I would say that I haven't specifically seen that ascites is very common after the FGFR2 inhibitors, but in general, their tumor can grow or spread to different places like the peritoneum or the lungs or the liver or the lymph nodes. And so the types of complications people can have all depends on where the cancer spreads to. And certainly the ascites is one of the complications if it spreads to the peritoneum.
Okay. The next question is, what are the requirements to enter this clinical trial? Are foreign person not residing in the U.S. be eligible to join the clinical trial? The current TAS 120 study is a global study, but not in every country in the world. We have clinical sites or institutions or hospitals participate in Europe, in Asia Pacific, and obviously in the US. So I think that depends on where you live or located, and we can provide or you can find out from clinicaltrial.gov where the clinical trials is being evaluated, or which sites or institutions are participating in this study.
The next question is, are there statistics regarding actual eradication of cholangiocarcinoma tumors which are inside the liver in the bile duct with the FGFR inhibitors? That's also a good question. What we tend to see on TAS 120 and this class of drugs in general is that we tend to see shrinkage of the tumor, but I have yet to see complete eradication of the cholangiocarcinoma with this drug.
Okay, I'm going back to one question before. A patient had been have gotten biopsies 3 times. However, the biopsy was not sufficient to perform the molecular testing. And I think that the question is that is there any help to provide on a safely acquire a biopsy and in order to participate in the trial? For biopsy, sometimes if the tumor size is too small, it's difficult to biopsy, and in order to do these molecular testing, it requires certain amount of tumors, and therefore to extract the DNA in order to do these molecular testing. I think there could be other alternatives. For example, like Dr. Goyal mentioned, to use the ctDNA to test whether or not it can find the FGFR2 gene fusions. And I think Dr. Goyal, you have anything to add? How we can get a more appropriate or adequate tumor biopsies in this case?
Yeah, definitely. It can be certainly tricky in this disease to be able to access tissue sometimes, because either the tumors are too small or they're in a tricky place. And so I would say having the biopsy done in expert hands at a high volume center can sometimes be helpful in being able to access tissue. But then it is challenging sometimes, and I'd be happy to talk to anyone's oncologist or anything to help try to figure out safe ways to biopsy. Sometimes we don't do it in the usual way of putting a needle in the liver or putting a needle in the lung. Sometimes we have to do it from the inside by doing an endoscope. So there are different creative ways to sometimes get biopsy tissue.
Okay. The last question is that will TAS 120 accept patients with prior FGFR inhibitor? At this point, we have closed out the group of patients with prior FGFR inhibitor for the phase 2 part of this study. No prior FGFR inhibitor is allowed. For the phase 1 part of the study, we had involved previously with patients with prior FGFR inhibitor, and we are in the process of evaluating the data and determine what would be next, whether or not we are going to reopen the cohort or whether or not we are going to further evaluate in the future. But at the moment, we are not allowing patients with prior FGFR inhibitor into the TAS 120 trial, unfortunately. I think that's all the questions that we had received in advance. So Melinda and Rick, I'm going to need your help to open the floor for additional questions on the call.
Sure. At the moment, there's no new questions, but if anybody out there has a question, you can type it into the message box. And we have a few minutes left that Dr. Goyle and Dr. Hong might be able to answer for you. So I have a question. It's Melinda. Regarding accepting patients with prior FGFR inhibitors, you said that there's a possibility. Do you know a time frame before patients would know, or would we be able to tell patients that that's going to happen or not happen?
Right now we don't have the time frame for when that's going to be reopening. For the time being, I think that we cannot have this patient. Having said that, Taiho has a expanded access program. So if a patient or if the treating physicians really want the patient to receive TAS 120, and if the patient have prior FGFR inhibitor, the patient can, go to that route. And Dr. Goyle actually have experience with that. So she can definitely share.
Yes, I've certainly had multiple patients who have had an FGFR inhibitor previously and then got benefit from TAS 120. And I also have experience in being able to access TAS 120 through the expanded access program. Taiho is very generous, and they were wonderful to work with in being able to get access to that drug. It does require your oncologist writing a special personalized protocol just for you and getting it approved by the institutional review board. That's the ethical review board at your institution, and also approved by the FDA. But with some diligence and some determination, it can certainly go through. So if you're a patient that had a prior FGFR inhibitor, certainly consider using the expanded access program to access TAS 120 if that's what your oncologist recommends for you.
Thank you. That sounds good. I've got a couple more questions that have come in. Okay, Sherry asked, would you allow compassionate use, especially since it seems to be working with prior FGFR2 fusion? I think you guys just answered that. If there's anything else you want to elaborate on.
Yeah. Mm-hmm.
Go ahead.
Right. So the expanded access program is the compassionate use, and the treating physicians can apply through a web link that Taiho basically hosts, and then the application will be reviewed by Taiho. And there would be the process, as Dr. Goyle mentioned, the IRB approval, the FDA approval, and then once all these is in place, then Taiho can ship the drug to the institution, and the patient can receive the drug from that institution.
Perfect. Lisa asks, can you develop an Fgfr mutation?
Dr. Goyle?
Yes, in response usually to being on an FGFR inhibitor, sometimes people develop mutations in the area where the FGFR inhibitors bind. Sometimes also people just start off with an FGFR2 mutation, and that's what part of the genetic testing is all about, because there are patients with FGFR2 mutations who can have a good response to TAS-120. And so sometimes people start off with it, and sometimes people develop it in response to an FGFR inhibitor.
Okay. Gregory asked, any patients in the study who have the BRCA1 gene mutation?
That's also a good question. We do sometimes see that in addition to having the FGFR2 fusion mutation or amplification, people also have mutations in other genes that are walking alongside the FGFR. So that could be something like BRCA1 or KRAS or TP53 or any of these common mutations. We're still learning about how, if you have the FGFR2 alteration and another mutation, how that other mutation might impact how well you respond to TAS-120. But right now, we're still learning about that. The main thing to get onto this trial is having the alteration in FGFR.
Okay. Andrea asked, would you give the drug to those of us who've been on a prior FGFR inhibitor, the drug for compassionate use, which I believe you answered? There is a program for compassionate use or expanded access.
That's correct.
Yes. One of the questions always is, when someone is on a prior FGFR inhibitor, what is the reason they stopped responding to that other FGFR inhibitor? So what our research has shown is that if people develop certain types of FGFR2 mutations in response to being on the prior FGFR inhibitor, which you can study by either testing the blood or by doing a repeat biopsy, if people have one of a handful of mutations, TAS-120 can be good at being able to overcome those mutations, and people can get some benefit from TAS-120. But we're still very early here, and we don't always know what is the reason people stop responding to an FGFR inhibitor. And so if someone stops responding to an FGFR inhibitor for a different reason, like they didn't develop a mutation in FGFR, but they actually developed a mutation, for example, in BRCA1 or some other gene, then going on TAS-120 next may or may not be the drug that actually gives people benefit. So it certainly helps to talk to your oncologist about learning about what's the reason someone stopped responding to the previous FGFR inhibitor.
Okay, next question. The one person that had extreme growth, did they experience shrinkage or stability on their first FGFR trial drug?
Jerry, I think that might be a question for you, the patient all the way on the left on the waterfall plot.
On the left, so the patient who did not respond, correct?
Yes.
Yes, the one
Just
person
one
that had
patient.
extreme growth. Yes.
Yes, yes. Okay. This patient had one prior FGFR inhibitor, and the patient did not respond to that FGFR inhibitor and had short duration. I believe the patient came off study after 2 cycles of treatment, which is 6 weeks. And the patient subsequently enrolled to TAS 120, and this patient also did not respond to TAS 120 and came off after, I believe, less than 2 cycles of treatment.
Okay, next question. Are there any previous treatments that may eliminate a candidate for this trial? And is it possible to combine it with other treatments, namely immunotherapy?
Currently, TAS 120 is developed as a single agent. We have not had a plan to, in combination with other checkpoint inhibitor or other agents at the moment.
And the first part of that question is, are there any previous treatments that may eliminate a candidate for this trial?
No, for the current study, there is no limit on the number of therapy. And as long as the patient have 1 prior chemotherapy that contained gemcitabine or cisplatin, the patient will be eligible.
Okay, maybe a few more here. Can the CA19-9 go up while the trial is still working if it's been a good indicator of growth or progression in the past?
We have not, sorry, go ahead, Dr. Goyle.
I was just going to say, yes, the CA19-9 is a very helpful marker for us because we follow it over time, but the scans at the end of the day are the gold standard. And so while we use the CA19-9 to help us understand what's going on with the cancer, there are different reasons that the CA19-9 can go up. For example, if the bile duct is starting to get a little bit blocked because your stent is getting a little clogged, that can make the CA19-9 go up, even though TAS 120 is still working. So overall, it's an important conversation to be able to have with your oncologist, and also it's important to follow what's going on with the scans.
Okay, I think based off the map that you showed, Jerry, where in Wisconsin is the drug available currently or in the future, and why not Chicago?
I know Jim, who is the study manager on the trial. He knows every single site, so I'm going to have him answer the question. Jim, if you're still on the call.
Yeah, can you hear me?
Yes.
Hold on, I'm trying to find, what was the location?
Where in Wisconsin is the drug available currently?
Wisconsin. If you can give me a minute, I'll bring that up. I have it on my computer here. Okay. All right. I think it's the University of Wisconsin is the, I'm trying to get the investigator's name here. I believe it's Dr. Dembla. The Medical College of Wisconsin, and it's Dr. Ben George.
Perfect. So the next question is, why are they eliminating patients who previously used an Fgfr2 inhibitor when they showed promise in phase 1 trial?
I think that we exclude the patient who had prior Fgfr inhibitor in the phase 2 part of the study is to have a more homogeneous population so that we can really assess the effect that's comparable to, you know, other Fgfr inhibitor when we look at the efficacy. This is the main reason that at the moment for the phase 2 part of the study that we are going to basically exclude those patients who have prior Fgfr inhibitor.
Okay, next question is, how long does a compassionate approval take?
I think that I'm going to give it to Dr. Goyle again to share her experience. It could depend from what I know from institution to institution, but Dr. Goyle can share her experience for her patient.
Sure. The approval from Taiho is very quick. That happens usually within a week, but to give Taiho some wiggle room, probably somewhere between 1 and 2 weeks, but that happened very quickly. The part that takes time is the oncologist writing an individualized protocol just for you, and then getting that through the IRB, and then getting it through the FDA. That whole process can take weeks. I would say on our end, it took somewhere between 3 and 5 weeks to get that approved, but every institution is a little bit different.
Okay, Jerry and Luca, are you guys good for a few more questions? And if not, I can try to gather what's left and we can get them answered at a later time.
Okay, sure.
Sure, I'm happy.
A few more?
Sure.
Yep.
Okay. Are there patients in the study that have a BRAF mutation?
It's similar to the question about the BRCA1 mutation. There are patients who have different mutations concurrently with FGFR, but the impact of those mutations on people's sensitivity to the FGFR inhibitors is unknown. But we are actively collecting data to look at what are the other mutations people have with the FGFR. But again, the focus of the study is to target patients who have the FGFR2 fusion or mutation or amplification.
Okay. Have any of your patients in the clinical trial had to stop due to drug toxicity, severe fatigue, or nausea?
Dr. Goyle, what about the patient that you have treated? I don't recall in general that's the side effect that leading to dose interruption. Have you remember any of your patients?
I have treated people on a lot of different FGFR inhibitors, and I would say luckily fatigue is not a significant side effect of this drug for the most part. Some people do have nausea, and sorry, Melinda, what was the other side effect? Nausea or?
Severe fatigue, drug toxicity, and nausea.
I haven't had to stop anyone for nausea in particular. The things that I've had to reduce the dose for are sometimes people having their liver tests go up. I've had to lower the dose. That's been the main reason I've had to lower the dose in patients, but one patient, because the phosphorus wouldn't budge, even though we tried a couple of different acrobatics, and so we went down a little bit on the dose. But that patient was at 24 milligrams, and then she did fine on a lower dose. So on the whole, Jerry, you probably know the statistics of the percentage of patients who have been discontinued from the drug for side effects. But in general, I find that the most common reason people come off the drug is that it stops working at some point, as opposed to it not being well tolerated.
Mm-hmm. Sounds good. One more, we'll do one more question. If the tumor has metastasized, would a patient be eligible?
Yes. Say that again, I'm sorry, Melinda.
It says if the tumor has metastasized, would a patient be eligible?
Okay. Dr. Goyle, sorry for the interruption.
Sure, yeah, that's precisely the type of patient that would be eligible for this trial. So people who have small tumors that can be resected by surgery, those people, we recommend they go forward with surgery. But if the tumor, unfortunately, is not amenable to surgery and it has spread to different places in the liver or is metastasized outside the liver, those are the patients, as long as they've had a combination of gemcitabine and a platinum drug, that they would be eligible for this trial, with the caveat that they need to meet the other eligibility criteria as well.
That sounds good. For all the other questions that didn't get answered, I will gather them up and I will send them off to Jerry and Lipika, and can we get them answered that way? And we can get them back to people if Jerry and Lipika, if you're open to do that.
Yeah, sure. I have a few more minutes right now, so if you want to answer a few more questions, I'm more than happy to.
Sure. Yeah, we do got a few more minutes. If you guys are good, I'm good. Let's see. Do the Fgfr inhibitors respond best to fusions, amplifications, or translocations? Has there been any data shown on which the Fgfr inhibitors work best on?
That's a good question. The published data so far is from BGJ 398. That was a study that was published in the Journal of Clinical Oncology. And that showed that among the patients who had fusions, mutations, and amplifications, it's the patients with fusions that had significant shrinkage of their tumor. And the patients with mutations or amplifications are patients that had stable disease. They either had a little bit of shrinkage or a little bit of growth, but overall the tumor stayed relatively stable. In our experience with TAS 120, we also see that the patients who have fusions, translocations, or rearrangements in general are the ones that have the highest chance of having shrinkage of their tumor. But we certainly see patients with mutations or amplifications have stable disease sometimes for a period of time.
I think we've covered the rest of them from previous questions already. So I think that should wrap it up for us. Thank you, Jerry and Lipika, for a wonderful presentation and for joining us tonight. Thank you for all of you for joining us this evening. We hope you received and got some of your questions answered. And if there's any future questions, please just email to me and I'll make sure we can pass them on. Anything else, Jerry or Lipika?
No, thank you.
Thank you. Yes. Yes.
Right. Thank you so much.
Thank you for organizing, and thank you for Foundation to host this webinar. And we hope that this is informative, and we're happy to share the information. Thank you so much.
Thank you too. And I also wanted to state that this is being recorded, and so if you missed part of the webinar, or if other patients didn't get a chance, or caregivers a chance to see it, it will be posted on the website.
Thank you, Melinda.
Thank you, everyone. Have a good evening.
Good night, everybody.